Okay, we'll wait a little bit as everybody joins in. We have a lot of participants tonight. Good evening, everyone. We'll wait until everybody has joined before we start the introductions. Okay. Excellent. So, good evening, good morning, maybe to some of you. Good afternoon, everyone. And thanks again for joining this new webinar as part of the Precision in Eye Health webinar series. Tonight we have a very special treat for you. We have a giant in the field of electrophysiology, Prof Graham Holder, who will be giving his talk. I see we already have 400, 500 participants, so it's a much anticipated talk. Prof Caroline Chi will be hosting this session and will be leading the discussion at the end of this webinar with Prof Graham. Let me give you a brief introduction about Prof Graham. I think he needs no introduction, but I'll do it anyway if you allow me, Prof. Prof Graham Holder has held Hong Leong Professorship in the Yong Lu Lin School of Medicine at the National University of Singapore since 2017, having previously been consultant and director of electrophysiology at Moorfields Eye Hospital from 1995. He has over 270 peer-reviewed publications, but most importantly, has over 27,000 citations, and he has over 45 book chapters, co-edited the Atlas of Chorioretinal Dystrophies. He co-authored the American Academy of Ophthalmology monograph on visual electrophysiology and was on the editorial committee of the recent AAO Basic and Clinical Science course, Retina and Vitreous. He accepted the honorary professorship of at the University of College London Institute of Ophthalmology in 2007 and of University of Sydney Medical School in 2013. He is an honorary fellow of the Academy of Healthcare Science, a fellow of ARVO and EVER. He is the past president of EVER and a member of the Scientific Advisory Board of SOE, and was a long-term board member of the International Society for Clinical Electrophysiology of Vision, ICEV, and has lectured extensively throughout the world. He has received AAO, EPAO Achievement Award, named Visionary of the Quarter by the European Vision Research Gateway, and is part of the top 2% world scientists by the Stanford University guideline. He also received the prestigious Alcon Award in 2010 and the Edridge Green Medal from the Royal College of Ophthalmologists, and recently the J. Donald Gass Medal for from the Macula Society, which is a huge achievement. Most importantly, Prof. Graham remains a passionate teacher and researcher, striving to help and improve patient diagnosis and management around the world. So, Prof. Graham, we're very privileged to have you with us tonight. Thanks again for accepting to give this talk, and we are all looking forward to this talk. Again, to everyone, please remember, if you have any questions, use the Q&A section, ask your questions, and we will answer them at the end with the discussion led by Prof. Caroline Chi from NUH and NUS. Prof. Graham, the floor is yours.
Welcome, everybody. And that gets around the good morning, good evening, good afternoon bit. Thank you for joining. I hope you enjoy what's about to come. I'm going to talk about visual electrophysiology. I know that most people will not be electrophysiologists, so I'll quickly run through the types of testing we do. This is the visual system. I'm sure you're familiar with that. And we can do visually evoked potentials to look at the response of the cortex, which after all is pretty close to where vision actually takes place once the eye gets its messages there. But the VEP arising in the cortex is non-specific. And I'll go through the details of the test a bit later. Moving into the retina, we can do an electrooculogram to look at the interaction between the RPE and the principally rod photoreceptors to look at the health of the retinal pigment epithelium. And then we get the ERG, or electroretinogram, which is a mass response to a luminance stimulus of the outer and inner retina. So it comes from photoreceptors and the inner nuclear layer. And we can separate rod function from cone function, etc. But the full-field ERG will be normal if dysfunction is confined to the macula. Although the macula is cone dense, the majority of the cone photoreceptors are outside the arcades. So we have to have specific measures to test the macula, and we can use a pattern ERG, which uses the same stimulus as a pattern VEP, or we can use a multifocal ERG, which is a luminance stimulus, and then some very complicated or rather clever cross-correlations produce these mathematical constructs, which are actually mathematics rather than actual electrophysiology, but they do a pretty good job. So why do we need electrophysiology? Well, the patient comes with visual symptoms, and the symptoms may give an indication as to the system involved that's affected. So if a patient presents with night blindness, we'd be thinking about the retinal rod system. If they've got photophobia, we'd think about generalized retinal cone system dysfunction. But if you have acuity reduction, it could be optical, it could be macular, it could be optic nerve, it could be cortical, etc. You may see a fundus appearance that you recognize, you may not. Then again, if you look at the fundus and you see a mild abnormality and the patient is complaining of marked visual loss, are they exaggerating to persuade, or could they possibly have dual pathology with a lesion behind the globe in addition to a mild abnormality in the retina? With a child who has nystagmus or roving eyes, you need to know whether this is a benign idiopathic eye movement disorder or whether it's a potential blinding disorder. Patients with a family history of genetically determined disease, monitoring treatment efficacy or safety. And of course, the reason electrophysiology is so valuable to us is that it provides objective functional data. So how do we do it? Well, we use a matched retinal response to a luminance stimulus. We change the adaptive state of the eye by doing dark adaptation, stimulating preferentially the rods, and then using photopic adaptation to get cone responses. We need electrodes. These are the ones that are in reasonably common practice. The HK loop from Marco Helina's lab, the DTL, gold foil, all preserve the optics of the eye and can be used for pattern or full field stimulation. The DTL and the Buren-Allen, the ERG jet and the Buren-Allen, which are contact lens electrodes, obviously affect the optics and can't be used for pattern ERGs. Now, these are all pattern ERGs, all full field ERGs from a normal subject under dark adaptation to a blue light, a red light, and a white light, and they're all different. Now, quite clearly, if I was talking to somebody in Japan, somebody in Germany, somebody in France, and we had French, Japanese, and German going on, it wouldn't be much communication, and the same applies for electrophysiology. So we need standardization, and that's enabled by the International Society for Clinical Electrophysiology of Vision, and we'll talk about those in just a second. But the only thing I'd like you to recall from this slide is that if we use a bright red flash under dark adaptation, we get an early response which comes from the dark adapted cones and a late response which comes from the rods. Now, the cones don't contribute to vision under dark adaptation, but they do contribute to signals, and that's particularly the case if there is rod disease. Now, these are the main standard responses. We dark adapt the patient for 20 minutes, and then we use a Ganzfeld bowl, shown here, that's one of them, to stimulate. This provides a uniform illumination across the retina. We start off with a dim flash in a dark adapted eye. The numbers here, DA001, DA10, the smaller the number, the dimmer the flash, the brighter the number, the brighter the flash, and the scales are in microvolts and milliseconds. With a dim flash in a dark adapted eye, we get a positive going wave known as a B wave, which arises in the on bipolar cells of the rod system. So it gives us a measure of sensitivity, but it doesn't give us a measure of specificity. If we have photoreceptor disease or inner retinal disease, we could easily lose the B wave. We then need a measure of specificity, and now we use a bright flash under dark adaptation. We now have the A wave, which is negative going, which comes principally from the rod photoreceptors in the normal retina, and the B wave continues to come from inner retina. We then turn on the background light in the Ganzfeld, restore the retina to photopic conditions, standardized background intensity, standard length of timing, and then we flash a light at 30 times a second. The temporal resolution of the rod system is poor and the rods can't respond, and in addition, they're being saturated out by the background. So this is a sensitive measure of cone function because it arises at an inner retinal level. and then specificity within the cone system is achieved with a single flash cone ERG. And now we have an A wave coming from cone photoreceptors and off bipolar cells. And the B wave is now a synchronized response. You will recall that in the cone system, we have both on and off bipolar cells. If you have a very short duration flash, which we have, it's off, and the on response and the off response are synchronized, and they join together to form the B wave. Analysis is size, timing, and shape, and this is a minimum recommendation. Now, this is the type of stimulus we'd use for a pattern ERG, and pattern ERGs are pretty small signals. In the full field ERG, we're at hundreds of microvolts, and the pattern ERG, we're less than 10 microvolts. But once the technical factors are considered, and technicians do need adequate training, the test, retest, and trial-to-trial variability of a pattern ERG is not significantly different from a full field ERG. In terms of origins, we have the N95 component, which from our clinical work and Laura Frischman's lovely experimental work, we know arises exclusively in the retinal ganglion cells. And P50, although probably about 70% comes from the ganglion cells, is driven by the macular photoreceptors. So if we have macular disease, it will affect the P50 component of the pattern ERG. But if we have disease which is confined to the ganglion cells, either primary ganglion cell dysfunction, such as Leber, hereditary optic neuropathy, or dominantly inherited optic atrophy, or secondary retrograde degeneration of an optic neuropathy, we can get sparing of P50 and reduction in the N95 component. VEPs are non-specific. They're very sensitive means of looking at the intracranial visual pathways, but they can be affected by anywhere anterior to the cortex, including the chiasm, the optic nerve, the macula, vitreous opacities, lens opacities, incorrect refraction, etc. If we do it properly and we get electrodes at the back of the head, the ophthalmologists have positivity going upwards. We have a P100 facing upwards. And all the early work done by neurologists and neurophysiologists, because they have positivity downwards, it's an inverted signal. Now, this is a patient who's 50 years of age. It was one of the first ones that was presented to me after I moved to Singapore from Moorfields. The patient's got a blind left eye with a very pale disc and has a very pale disc in the right eye with progressive visual loss. 10 years prior to this, she'd been told that there was nothing could be done about her left optic neuropathy. Sadly, she has a huge intracranial mass lesion, and that's why she has blind in one eye and markedly reduced visual acuity in the other. And when we look at the electrophysiology, in the blind left eye, we have no detectable pattern VEP, we have no detectable flash VEP, but we do have a detectable pattern ERG. The early P50 component driven by the macular photoreceptors is present, but of early timing. We've lost most of the N95 component, which comes from the ganglion cells. And in the right eye, with the progressive visual loss, we have a normal amplitude P50, which is slightly short in peak time. We've lost some of N95, so there's ganglion cell involvement, no pattern VEP, delayed and reduced flash VEP. So the pattern ERG remains detectable in optic nerve disease, even in an eye with no light perception, providing the patient can maintain fixation. ERGs in this patient are normal, and it's very rare, if not at all, that you get any kind of transsynaptic anterior degeneration. Now, this is from Laura Frischman's beautiful work confirming what we'd shown clinically. If you then inject TTX, which blocks all spiking cells into the vitreous of a macaque, macaque has got a similar pattern ERG to a human, slightly deeper N95. But if you look at the signals here when you inject the TTX, N95 reduces, P50 drops down to about a half and becomes shorter in peak time. And this is exactly what we've just seen in end-stage ganglion cell disease in a human. So applications of pattern ERG, obviously is assessing the macula because it's driven by the macular photoreceptors, assessment of central retinal ganglion cell function, and improved interpretation of VEP. Now, if we have photoreceptor disease, because the A wave comes from the photoreceptors, we would expect the A wave to be reduced. So if we have our rod-specific ERG, the DA01 response, below the cone threshold, hence rod-specific, the B wave is reduced. And then when we use the bright flash and the A wave is then reduced, this confirms the dysfunction to be at the level of the photoreceptors. There's lots of different photoreceptor disorders. There's no point in me going through the list. You can look those up in a textbook. There are many acquired diseases. There are many inherited diseases. But the most important thing is when you're looking at interpretation, you relate the findings to the signs, the symptoms, the history, the inheritance, and of course, the underlying pathophysiology. You have to attempt to understand the disease. If we have inner nuclear layer disease, either signal being prevented from transmission at the first synapse or generalized inner nuclear layer disease, such as a central retinal artery occlusion perhaps, then the A wave generated by the photoreceptors will largely be preserved. The B wave will be reduced, so the waveform will be dominated by the negative going A wave, and this is called a negative ERG. So in this instance, where we see a rod-specific ERG which is undetectable, it doesn't tell us where the problem is. But then when we use a bright flash under dark adaptation, the normal A wave tells us the photoreceptors are working normally. The B wave is much smaller than the A wave, and this is a negative ERG waveform. There are lots of causes of that too. Some inherited, the most common being X-linked retinoschisis and congenital stationary night blindness, and a whole bunch of other acquired diseases. So the principles of electrophysiological interpretation are firstly ascertaining the origins of the signals. Just because we flash a light and record some electrical signals, it doesn't actually tell us exactly where the signals come from. That has to be ascertained. The findings then have to be related to the necessary other factors, but most important of all, never ever make the electrophysiology fit the diagnosis. The electrophysiology is the truth. It represents the underlying pathophysiology, so the diagnosis must fit the electrophysiology. Now, one of the problems is when we teach electrophysiology, is some people teach by disease, but that's not the way it goes, really. The patient doesn't come to you with a diagnosis stamped on their forehead. They come saying, "Doctor, I can't see to read." First of all, the basics: thorough clinical examination, accurate refraction, medical, surgical, drug, dietary, family history, all the basic essentials. Then if you've got a fundus which is abnormal, perhaps it will explain the visual loss, perhaps it won't. That depends on the nature of the abnormality. If the fundus is normal, then you're faced with occult macular dysfunction, retrobulbar dysfunction with no physical signs in the globe of the eye, or non-organic visual loss. Now, if the macula looks abnormal, then we need a pattern and multifocal ERG to look at central retinal function, and an ERG will then determine peripheral retinal involvement. In inherited diseases, we would have a macular dystrophy, a cone dystrophy, or a cone rod dystrophy. And remember that these terms are electrophysiology derived. So if the ERG is normal, the problem's at the macula. Cone dystrophy is cone disease, cone greater than rod disease. It would be very rare for rod cone disease, such as retinitis pigmentosa, to present with visual loss. The most common of the inherited diseases causing the maculopathy would be ABCA4, Stargardt disease, or PH2, which used to be called RDS peripherin. Now, these are all images from patients with ABCA4. They're all different. And quite clearly, there's going to be marked variation in phenotypic expression when you get these huge abnormalities in the retina. Also, the stage at which you examine the patient is going to change the appearance. These three patients here are the same patients here, but 10 years later. In each case, the fleck lesions have largely gone, the atrophy has vanished. Here, where we started off with hyper-autofluorescent flecks, representing metabolic overload at the level of the RPE, that's converted into cell death, and it's now hypo-autofluorescent. So these are all the same disease. Now, when Noemi Louise came to Moorfields at the late 90s to do a fellowship with Alan Bird, Alan had the view, and this was before the ABCA4 gene was fully evaluated, Alan had the view that he wasn't dealing with one disease. So what we did was examine many patients with Stargardt and separated them by ERG, groups 1, 2, 3, according to whether the ERG was normal, additional cone dysfunction, cone and rod dysfunction. And we obtained cross-sectional data which suggested group 1, where it was pure maculopathy, to be associated with much less progressive disease. So could that be prognostic? And is the Stargardt disease itself necessarily progressive? Some of those questions were answered when Kaoru Fujinami, who's now a professor in Tokyo, came back and did a fellowship with myself and Andrew Webster and Mike Magliades. And every single patient from the original cohort which had initial rod involvement came back, showed significant electrophysiological and clinical deterioration, but only 20% of the patients who had normal full-field ERGs showed deterioration, and the prognostic value was confirmed, being accurate in 80% of patients on the basis of an ERG. This is a typical case. Patients got central atrophy, some fleck lesions, which show better on autofluorescence imaging and central atrophy. And the question is the ERG grouping. OCT just shows the central changes, no surprise there. And when we look at the full-field ERGs, they're completely normal. There's loss of the 15-degree pattern ERG, and we can also use a 30-degree pattern ERG, and that shows there is preservation of function between 15 and 30 degrees eccentricity. It's smaller than the normal, but it is pretty good. And the mutational data are unknown. Now, when we look at the multifocal ERG, it's perhaps a little surprising because the defect that we see in the fundus is centralized around the fovea, but the defect we see in the multifocal is not centralized. And that's, of course, because patients who have central visual field loss maximize their visual disability by using eccentric fixation. The multifocal system, which is black box technology, doesn't know where the patient is fixating. It assumes the patient is fixating centrally. So this is simply an apparent loss on the multifocal displaced due to eccentric fixation. And when you're doing any kind of test in medicine, you have to be aware not only of the advantages, but also of the disadvantages. Is it necessarily progressive? Well, this is a patient who's had Stargardt for 30 years and has completely normal full-field ERGs, but no detectable pattern ERG. Now, the other form of use of a pattern ERG is measurement of optic nerve disease, because we can test the function of the macula. And if you've got optic nerve disease, you may have visual acuity loss, color vision deficit, field loss, a scotoma which the patient thinks is something missing, and they have a relative afferent pupillary defect. But of course, when you look at macular dysfunction, it's pretty much the same list, except the positive scotoma, something's been placed there to stop them seeing, they want to look around it. Patients with maculopathy may have an RAPD, but then you've got the distortions, the metamorphopsias, etc., which tend to be confined to macular disease. And importantly, the VEP can't distinguish. We need VEP and pattern ERG. Now, the fantastic work done by Martin Halliday in the early 70s with pattern reversal VEPs led the grounds for VEP being an accepted clinical tool. He showed that pattern reversal VEPs was delayed in optic neuritis, the acute manifestation of optic nerve demyelination, but also, and most importantly, the delay remained after acuity recovery. So the patient gets their acuity back, they still get a conduction delay, and even more important, an eye with completely normal examination, no signs or symptoms of optic nerve disease, could show subclinical delay. This is a typical patient who's got a 7-month history of optic neuritis, acuity is recovered, VEP is from the right eye, normal, VEP from the left eye, pattern reversal here, flash here, pattern ERG here, is delayed, flash VEP is delayed, pattern ERG shows a beautiful P50 component, but there's selective loss of N95, which doesn't come down below the baseline, in the eye with the optic neuropathy. So this is retrograde degeneration to the retinal ganglion cells. Now, this is another patient who presented with blurred vision in the left eye after exercise or a hot bath. So this is commonly known as a UTOF phenomenon, and is usually a function of a fairly severely demyelinated nerve. Acuity was normal, there was no relative afferent pupillary defect, Ishihara was slow, but no other errors. And when we look at the electrophysiology, it all now makes sense, because the severely affected eye with the UTOF has a massive delay, loss of N95, shortening of P50 in the pattern ERG, but the other eye, which is asymptomatic, also has a massive optic nerve conduction delay. And this is one of the things that Martin showed, which was so important, the ability of a VEP to pick up subclinical optic nerve conduction delay. And of course, if you've got a delay in both eyes, you won't get a relative afferent pupillary defect. And if any of you are still doing emergency work or teaching people to do emergency or casualty work, and a patient comes in with the symptoms of an acute optic neuritis, but no signs, always consider the possibility of early subclinical involvement in the other eye. Now, this is a patient who's got litigation pending following a traffic accident. and is claiming counting fingers vision. And the pattern ERGs are completely normal, so there's no maculopathy, there's no retinal ganglion cell dysfunction. When we look at the VEP, there is, however, a delayed pattern VEP from the right eye and a normal pattern VEP from the left eye. Now, a patient with counting fingers vision should not have a detectable pattern VEP. So is this exaggeration? Well, it's not even as simple as that, because when the patient is observed, these tests here, we have the patient under constant observation. So we knew that she was screwing her eye up, she was trying to look aside, she was partially closing her eyes. When she was aware she was under direct observation and the technician was telling the patient, look at the screen, keep your eye open, concentrate, then the pattern VEP from the right eye is completely normal. And this is simply deliberate manipulation by the patient to attempt to deceive. Some patients will exaggerate symptoms to persuade. This is a patient who's attempting to deceive. But note the delayed pattern VEP. Now, this is a patient who's 45 years of age, referred by an ophthalmologist to establish normal optic nerve function. Mild Ishihara deficit and color vision, acuity not too bad, fields were variable, and the VEP was delayed from the right eye, not the left eye. So we must do a pattern ERG. The pattern ERG is bilaterally subnormal, so the patient has bilateral maculopathy. We then do a full field ERG, and we now again see the ability of the ERG to separate rod function and cone function. When we look at the dark adaptive responses, which are rod dominated, they're completely normal. The flicker ERG shows a marked delay and is profoundly subnormal, so there is profound generalized retinal cone system dysfunction, in addition to the maculopathy. So this patient has a cone dystrophy, and the imaging is completely normal. The fundus is bilaterally normal, the autofluorescence is completely normal, the macular OCT is completely normal, and yet the patient has a cone dystrophy. So there are important learning points here. Normal retinal structure does not mean normal retinal function. And equally, VEP delay does not mean optic nerve disease. We've seen it in macular disease. We've seen it in patients who have deliberately affected and influenced the recording. Now, what are the retinal disorders likely to be mistaken for optic nerve disease? Well, there's a whole bunch. The most common is perhaps posterior scleritis, which is often missed by neurologists, but not by ophthalmologists. And most of these, again, you can just look through the list. Now, what about the delay in macular disease? Can it be as severe as that in optic nerve disease? Well, sadly, from a diagnostic point of view, the answer is yes. Here's a patient with APCA4 retinopathy, Stargardt disease, with 140 millisecond VEP peak time. So very delayed and undetectable pattern ERGs. Now, when we did a series of patients, and this is more than 200 patients with macular disease, 500 with multiple sclerosis, and we looked at the pattern ERGs in relation to the P100 peak time. And the latency in macular disease, shown in the crosses, could be 10 milliseconds, 20 milliseconds, 30 milliseconds, 40 milliseconds, or even more. But when we looked at the same patients in the pattern ERG, by the time they've got 10 milliseconds delay, the mean P50 is down to 50% of normal. And by the time there's 30 milliseconds delay, the pattern ERG will usually be undetectable. So we nearly always have a means of distinguishing optic neuropathy from the pattern delay, delay in optic nerve disease from that in macular disease. Now, one of the other symptoms, of course, which is commonplace is, doctor, I can't see in the dark. But then you've got, of course, what does this mean? I mean, I personally can't see in the dark, and you, when you're in the dark, almost certainly can't see in the dark. So what do we mean by that? Well, in Singapore, where I now live, it's even more complicated because there's so much urban light pollution. You can't see stars very often. And I have to rely on testing my own eyes when I go back to Europe or somewhere in Asia where there is countryside, and it doesn't exist in Singapore really, to see if I can see stars. So do you see a true night full of stars is one question to ask. Being careful, because some inherited diseases, night blindness, ask if they're the same as their friends and their relatives. And another useful means of finding out whether they've got problems is, can they find their own seat in the cinema or the theatre when they go from the private foyer? First steps again, the routine, symptoms, examination, history, medical and surgical history, diet. Is it inherited or acquired? That will be based on what you ascertain above. And the investigation, of course, will be ERG. There are many inherited causes of night blindness. Some are photoreceptor, such as rod-cone dystrophy. Some are intraretinal, such as congenital stationary night blindness. And the way those can be distinguished, we'll address shortly. Now, the most commonly inherited retinal disease causing night blindness is retinitis pigmentosa, or rod-cone dystrophy. And the patient with this type of pigmentary change in the retina, with narrow vessels and pale disc, will have no detectable ERG. You get pigment migration from RPE. So when photoreceptor cells die, you get pigment migration from RPE into neural retina, and that's why you get pigment changes. So when you see pigment, you know you have cell death and therefore very advanced disease. It affects 1 in 4,000, and all inheritance patterns are known, and very common syndromic would be Usher syndrome, Bardet-Biedl syndrome, etc. Now, when the patient presents to you, they don't present with the label, they present with poor night vision. And in this patient, when you look in the eye, the right eye is abnormal. There are no bone spicules, but there's this grayish mottled appearance, which we associate with outer segment morphological change, which some people term outer retinal atrophy. There are 1 or 2 bone spicules in the left eye, but the patient then says to you, because you now know this patient has RP, how bad is it? And then you have to sit and think, well, is this really bad or is it? And it's difficult to tell. Now, we can use autofluorescence imaging, and we can now see the ring of increased hyperautofluorescence surrounding the fovea, which my group first reported the significance of back in 2003. And we used pattern ERGs to show that there was function preserved within the ring and lost outside the ring. And that was confirmed with spectral domain OCT, where you see preservation of outer retinal structures within the confines of the ring. But of course, this is only telling us what's going on in this central retina. It's not telling us what's going on in the periphery. And for that, we need the ERG. And this patient actually has very severe disease. Despite the normal acuity, the rod-specific ERG is bilaterally undetectable, severe rod system dysfunction. The A wave is down to 15% of normal. So 85% of those retinas have already lost function. Flicker ERG, generalized delay, marked amplitude reduction, generalized dysfunction. If you had what's known as sector retinitis pigmentosa with restricted disease, you would find amplitude reduction without delay. And the delay is a measure of dysfunction. When we go to look at pattern ERG, it's small, 15-degree field is subnormal. And then when we go from 15 degrees to 30 degrees, it confirms that we've already lost function between 15 and 30 degrees eccentricity. But this is very advanced disease. Congenital stationary night blindness is one of the other main causes of night blindness, which has to be distinguished from RP because it's not a potential blinding disorder. It was divided originally into complete and incomplete by Yozo Miyake back in 1986. And the complete form is often associated with myopia, and the incomplete also can be associated with myopia, but it's because it's got much more cone abnormality, you can often get nystagmus. And indeed, sometimes that's the way the patient presents rather than with the night blindness. Now, this is a 7-year-old who comes in carrying a diagnosis of retinitis pigmentosa, which was made elsewhere. And when we look at the dim flash, it is indeed undetectable, as we saw with the patient with RP. But when we then look at the bright flash A wave, it's completely normal, which excludes retinitis pigmentosa by demonstrating normal rod photoreceptor function. There's a negative ERG, which confirms it's CSNB. And if we look at the shape here of the single flash, it's a broadened A wave trough, sharply rising peak, reduced B to A ratio. And this is diagnostic of preservation of the off pathway and loss of the on pathway within the cone system. So this is the so-called complete CSNB. Yozo based it on whether there was or was not a detectable rod-specific ERG, but there's detectable rod function. We know from work, which I'm not going to go into in detail, that the off pathway is preserved in the complete form of CSMB, but the off pathway is affected. And we can use a long duration stimulus, shown here as 200 milliseconds, turn the light on, see an on response, turn the light off, see an off response. In the complete form of CSMB, the off response is normal. In the incomplete, it's not. It's very abnormal. So you've got much more underlying pathophysiological change in the cone system with the incomplete CSMB, and you get these far, far, far more abnormal ERGs with the characteristic triphasic, very small signal, and here with the single flash photopic ERG, this very small U shape. The A wave here preserved because of off pathway preservation, off wave here lost, and therefore the A wave is not affected. Now, this is a patient who's got a lifelong history of night blindness, small white dots extending into the mid-periphery, so it looks as if it could be a disorder known as fundus albipunctatus, which is fundus white dots, which is very nice. And when we do cone-derived ERGs, all of the cone ERGs, including on and off and S cones, are normal. And when we look at our standard ISO bright flash dark adapted ERG, it appears to be negative with the B wave smaller than the A wave, and the rod-specific ERG is undetectable. So have we got the diagnosis right, or is this a form of congenital stationary night blindness with negative ERG? Well, when you're interpreting ERGs, as alluded to earlier, we have to identify where the signals are coming from. Then we have to relate the findings to the pathophysiology of the disorder we're attempting to diagnose. And can the ISO ERGs answer the question? Well, we know quite a lot about fundus albipunctatus. This is from Gabe Travis's beautiful review back in 2007. It's recessive and it relates to variants in RDH5, which encodes 11-cis-retinol dehydrogenase. So it's part of the recycling within the retinal pigment epithelium. When light hits rhodopsin, photoisomerization takes place, and we end up, after the phototransduction cascade has done its job, with all transretinol, which gets transferred into the RPE for recycling back into retinal. And RDH5 links with cellular retinaldehyde binding protein to send the whole process back together again by switching retinal back into the photoreceptors. And we also know that if we allow long enough for rhodopsin to regenerate in darkness, it will normalize. And this is best done overnight. So we've got a problem which is related to a regeneration. There's no structural abnormality. So when we do the same thing and we test the same patient after extended dark adaptation, we now see the ERGs from the rod system are completely normal. So we've now demonstrated what we know of the underlying pathophysiology. This is consistent with RDH5 variant, and the patient does indeed have fundus albipunctatus. So in that case, why is the DA10 ERG electronegative? And it goes back again to understanding signals and understanding what we're dealing with when we look at rods and cones. This is a rod system in a normal human being in darkness, and as we increase the stimulus strength, so the B wave comes, the A wave starts to increase, and no matter how bright we get, the B wave stays larger than the A wave. In the cone system, that doesn't happen. When we look at the cone system here we see the maximum amplitude of the B wave, and as we then further increase, we see a phenomenon which was originally described as the photopic hill, because it was observed in light-adapted normal patients, as some normal subjects even. And as we increase the stimulus strength, so the A wave coming from cone photoreceptors and off bipolar cells increase, the B wave, which is a synchronized response, starts to drop off. And some very nice work by Shinji Ueno in Minao Kondo's lab showed that this resulted from a desynchronization of the on and off responses. And then our clinical work showed that this also occurs in the absence of rod function in darkness. And when we just go back briefly and look at that shape, look at this waveform change and the way that it happens. Now we go back to our patient. First of all, we use the dark adapted red flash, and it shows a beautiful high amplitude dark adapted red response and no rod component. Now this, of course, is expected because after 25 minutes dark adaptation, there can be no rhodopsin because of the pathophysiology. And we then see exactly what we saw in the photopic hill in the normal and light adaptation, where the B wave starts to become smaller than the A wave, the A wave increases. And I coined the term for this a few years ago of being a pseudo-negative ERG, because it hasn't got the same implications for the site of dysfunction or the nature of dysfunction as a true negative ERG, even though it looks like it. And I wrote a discourse with Omar Aru, one of the previous lecturers on this series, which was published a couple of years ago. So in RDH5, there's no structural abnormality. The dark adapted red flash is needed. And importantly, similar findings can occur in vitamin A deficiency, being vitally important, and Gucci disease, which is often seen in Japan and very rarely outside. Now, this is a patient with RP. See the changes that we associate with autolateral segment morphology and the classical changes with the autofluorescence, the ring of hyperautofluorescence. And then when we look at this patient, we've got a red flash ERG which shows cones but no rods. The cones themselves are very, very, very abnormal. But when we look at the DA10 response, it itself has a B wave smaller than the A wave. And even in patients with RP, you can get a pseudo-negative ERG, where the B wave is smaller than the A wave. And this is because we've got no functioning rods left. We've only got functioning cones. It's very severe disease. And it's the same process that we've just seen in RDH5, but here it's very, very small because the cones themselves are very much involved. Now, to change focus completely towards the end, just to show how ERGs can be used to monitor the efficacy of treatment. This is birdshot retinochoroidopathy, which is, sadly, I don't see in Asia. Well, not sadly, but I don't see it in Asia. But we saw a lot in Europe, and I understand there will be Europeans on the call. So it's related to HLA-A29. It's very unpredictable. Management is tricky. And they have these deep-seated creamy lesions. There's a erythritis, vasculitis, etc. And flicker ERGs are commonly delayed. Now, in this particular patient, we've got floaters in the left eye with blurred vision. There's diffuse retinal edema on the OCT, some mild changes on the autofluorescence, and the right eye is completely normal clinically and imaging and OCT. But when we look at the electrophysiology, we see the left eye is very severely affected. Loss of the rod-specific ERG, very small bright flash, delayed flicker, loss of the pattern ERG both to 15 and 30-degree fields. The right eye has subclinical involvement, showing a flicker ERG delay. Now, this patient was then treated with steroids for 3 months with 60 milligrams daily, and the left eye ERGs have recovered almost completely. The right eye is completely normal, except pattern ERG, which hasn't come back up. But when you look here, the left eye after treatment and the left eye before treatment, pattern ERG has completely disappeared and now returned. So we can demonstrate efficacy of treatment objectively. And in birdshot, you can titrate the degree of treatment, how severely or how mildly you need to treat, by looking at the effect on the ERG. And I remember seeing one patient who was on an almost homeopathic dose of 1 milligram of prednisolone per day. And that was enough to keep her ERGs fine. But as soon as she stopped it, they went crazy again. So the ERG, objective efficacy of treatment. Now, we're closing now with the structure function. So do structural abnormalities predict function? Well, we've already seen that there are challenges there. We've seen a patient with a cone dystrophy and normal imaging. We've seen lots of different patients with ABCA4 disease. Now, this is one of the causes of negative ERG. This is a very typical case of X-linked retinoschisis, retina split. That's what retinoschisis means. You can see it beautifully on the OCT. And the spoke wheel lesion, which occurs at the fovea. And these are associated with negative ERGs. 50% of patients don't show peripheral schisis, and this can change as they age. But these 3 patients don't show any schisis whatsoever, and yet they have genetically confirmed variants in schisis. Some of them got a ring of autofluorescence, and these are X-linked retinoschisis, but you wouldn't think so until you do the ERG. This patient has poor color vision, age 5, very, very pale discs, diagnosis of heredofamilial optic atrophy, MAC OCT shows no evidence of maculopathy, but when we look at the ERGs, the patient has a cone dystrophy. Rod function normal, bright flash normal, red stimulus shows no cone component, but a good rod component. Flicker ERG, note the calibration scale is different, very delayed, very small, and no detectable pattern ERG. So this is a cone dystrophy masquerading as heredofamilial optic atrophy. Now, this is a patient who's got night blindness and family history of RP, no ocular signs so far. This is the referral at Moorfields, and the imaging are normal, and the patient has very severe rod system dysfunction with loss of the DO01 response and a markedly subnormal A-wave. But of course, we can't make a diagnosis of retinitis pigmentosa, which is what is considered, until we've done the necessary. Identify the signals, relate to the pathophysiology, and don't make the electrophysiology fit the diagnosis, because the diagnosis may not be right. With our red flash, we see there's a cone component and no rod component, and the cone ERGs are normal, so this is a cone-isolated retina. In that case, it cannot be retinitis pigmentosa, because retinitis pigmentosa is a rod-cone dystrophy, and if there's no rod function left, the cones will never be normal. So this is not RP. Now, the patient, when they have an ERG, spends quite a lot of time with the technician, and the technicians, in my hands, are always taught to take a history, and the child was autistic, very poor diet, recent dry eyes, so the clinicians amongst you already realize that this is vitamin A deficiency until proven otherwise. That means it's treatable, and after 2 intramuscular injections, the so-called retinitis pigmentosa is cured, and the ERG is now completely normal with the introduction of vitamin A. So imaging is also non-specific. Those images were misleading, perhaps. Now, all of these patients have got very similar images. So the question that you have to answer is, how many diseases are shown on this slide? Have they all got the same disease? They've all got very similar pictures. There are 13 different disorders shown here on these autofluorescence images. So they're non-specific. They've all got central atrophy, some have got a ring, some have got speckling, but they're pretty similar. All of these patients have got variants in the same gene. They all look very, very different. The one that's classical is this, where there are nummular or coin-shaped defects, deposits, pigmentary deposition at the level of the RPE. It's very deep. It's not intraretinal. And all these patients have got enhanced S-cone syndrome or NR2E3 variant. You can also get the same gene with different fundus appearance. Now, we've seen this already with ABCA4 and CRX. But what's interesting here is that these patients with PRPH2 variant all have exactly the same variant in exactly the same gene, and yet they have completely different phenotypic expression. Macular dystrophy, cone dystrophy, macular dystrophy, severe cone rod. And it was Dick Weller's group in 1993, I think it was, who first showed that the same family could have different disorders with PRPH2. And what's interesting here is that the bottom 2 patients are a mother and a son. Are ERGs ever diagnostic is asked. Well, there are 3 very rare disorders. We wrote a summary paper on this in Retina a few years back. If anyone's interested, I would recommend that because it goes into these. They are very rare. So identification of the functional phenotype or of the genotype by structural features alone is often impossible. But imaging, it's wonderful. It's very, very powerful. It can reveal features which were totally unexpected. But as we've seen, it's often non-specific. A normal structure doesn't mean normal function. Electrophysiology, however, tells us about function, but that also very rarely makes a diagnosis, but it will give the nature and severity of the disease. It can direct and help with mutational screening and is very important when you're actually going through mutational data to work out whether it's certain variants are causative or not. And we've seen efficacy or safety of treatment. But really, we need both. Optical management needs structure and function. Now, I'm indebted to Clement Tan, who was the ex-chairman of my department, ex-head of my department, when I started. And he said, Graham, you're like a detective. And he quotes the CSI crime scene investigation, which I understand one of the favorite things they say is there is always a clue. And you concentrate on what cannot lie And that is the evidence. Well, of course, in medicine, it's the electrophysiology. Thank you very much.
Okay. Thanks a lot, Prof. Graham, for this wonderful talk. Okay, let me welcome on board Prof. Caroline Chi, who is a senior consultant from the Department of Ophthalmology at NUH and also clinical associate professor in the Department of Ophthalmology, NUS. Prof. Chi, thanks for joining us and hosting this discussion with Prof. Graham. To everybody on board, please, if you have any questions, type them in the Q&A. Prof. Chi?
Thank you, Graham. As usual, an excellent lecture, and I think very illuminating in many ways. Do we have any questions that the audience would like to ask Prof. Holder?
No questions so far. Maybe we can start.
Okay,
Yeah.
so let me just ask Prof. Holder something which really may be of interest to many of us who manage patients with high myopia. Have you found anything unusual about the electrophysiology in this group of patients with very high myopia?
Yes. I mean, basically, that's thrown me out considerably because when I was at Moorfields, high myopes were a rarity. And in Singapore, it's more common for people to be relatively high myopic than to be hemetropic. And one of the things that happens is that some would get some retinal dysfunction, mostly outer retinal, but occasionally inner retinal. And the multifocal ERGs tends to fade off towards the end as you go towards the periphery of multifocal ERG responses, so the responses get smaller. Now, whether this is related to axial length, I'm not sure. We haven't yet done the necessary analysis on that. But it's so we've got spherical myopia or axial length, and I'm not sure which is the relevant bit. But certainly, as you go towards the periphery in the field, which is 55 degrees, it gets smaller.
Right. Do you think there's any correlation between the electrophysiology abnormalities and the level of night blindness or difficulty seeing at night, which some of these people have? I mean, it's quite relevant to us because all our young men go for national service, and sometimes they stumble around in the dark when they, even with their glasses on. So if we could, correlate electrophysiology changes with functional difficulty seeing at night, then we could kind of maybe be more confident in saying, yes, this person really has difficulty seeing at night, and he's not making up stories or trying to malinger.
I mean, that really is the challenge, of course, because we see quite a lot of NS boys who come through, and there are some who clearly have absolutely pristine ERGs. They're completely normal in every respect, and they obviously don't really fancy wandering around in the dark, particularly if they, they just don't fancy it. But there have been some who don't fit into it, and some have got congenital stationary night blindness, because undoubtedly there. And then we've seen some who have a reduced B to A ratio and a mildly subnormal rod-specific ERG. So it looks as if there's very mild inner retinal dysfunction, but it is significant and it is there. And they tend to be ones who are -6 or above. But that's only on gut reaction. I haven't looked at this systematically. But it's concerned.
Right, sure. And
yeah, Prof. Chi, go ahead, please.
So another area which I think is maybe of interest is have you found any unusual electrophysiology changes in patients in whom the diagnosis of normal tension glaucoma has been made, and is other, and I believe there's some variations in this group of patients.
I mean, for those who are listening in Asia, you know that this is a major problem. For those of you listening in Europe or possibly even the States, you may wonder why the question of normal tension glaucoma has come up. The last time I was talking to one of the professors of glaucoma in Seoul, in Korea, she said that 70% of her patients in a university glaucoma clinic are carrying a diagnosis of normal tension glaucoma. 50% of patients in glaucoma clinics in Japan are carrying a diagnosis of normal tension glaucoma. Now, I've been looking at some of these with one of the neuro-ophthalmologists here, both Hazel Lin and Clement Tan, and also with glaucoma doctors Paul Chu and particularly Victor Koh. And we've been looking at a number of these patients, and Clement actually presented some data to NANOS, the North American Neuro-Ophthalmology Society, because out of 100 patients carrying a diagnosis of normal tension glaucoma, 40% of them appeared to have a non-glaucomatous optic neuropathy. Now, the implications here are potentially far-reaching, because patients who are NTG are usually treated by getting the pressure down. I mean, the patient goes to a glaucoma doctor, the first thing they do is try and get the pressure down. And sometimes patients have tube put in or they have glaucoma surgery. And even if they don't, they're on probably lifelong drops. And there are problems there with what's going to affect the anterior portions of the eye. There's quite clear toxicity which can occur with corneal damage, etc. So if we can get patients off anti-glaucoma drops who don't need them, then that would be beneficial. Now, at the moment, we're trying to write up a large series. The 100 patients plus a few more are being formally looked at. We hope to get a short report out soon, which will just demonstrate some of the stats to point out what the problem is, and then address it more systematically with a much larger paper, addressing much more into the various details and much more information.
Okay. Maybe let me ask a few questions from the audience, Prof. Graham, and maybe we answer them with short answers because they're more related to conditions. So Bo is asking, can you comment on ERG in blue cone monochromacy?
Yeah, they have S-cone ERGs.
Okay.
Sorry, hang on, S-cone monochromacy. Yeah, they don't. They have S-cone ERGs.
Okay.
So you can split achromatopsia into S-cone monochromacy or rod monochromacy. So it depends on which ones you've got left. So if you've got S-cone monochromacy or blue cone monochromacy, S-cone is probably a better term, then you have detectable blue cones and you can do shortwave cone ERGs detectable. You normally find that if you do conventional ERGs, the flicker ERG will be undetectable in the S-cone monochromats because S-cones can't respond at 30 Hertz. They can tail off much earlier than that. They don't have the temporal resolution that the long and medium wavelength cones have. And you will usually see a very small response in the photopic single flash ERG at about 50 milliseconds, which is where the peak time of the S-cone response usually is. So yeah, you have to do S-cone ERG specifically.
And does electrophysiology, Gary, tell us how fast, for example, RP progresses with age?
No.
Yeah, we predict? No?
No, I don't think so.
Okay.
I think it's important when you're dealing with prognosis in RP, obviously you take the family history, you take what's known of that particular variant, bearing in mind there are hundreds of different variants. But I think what's important is, and again, I haven't got this systematically looked at, but it does seem to work, is that when you're dealing with patients with very severe disease, they've got fields which are very constricted, they may be down to 5 degrees or what have you. Now, if the 30 Hertz flicker ERG, which is the best way of looking at the remaining cone function with the pattern ERG, if the 30 Hertz flicker is normal timing, then it suggests those central residual cones have got normal function. In which case, they're probably more likely to survive than the ones who are already dysfunctional. Because we know that some RP is self-limiting. the so-called classical RP can go down. The patient gets maybe these 5-degree fields, 8-degree fields, 10-degree fields, and then stabilizes. They're the ones who end up with pure gun barrel vision, if you want to call it that, or tunnel vision. But others go on to lose their central vision. And my gut reaction is that if they've got a flicker ARG which is really small but normal peak time, they've got a better chance of maintaining that central acuity.
Good. Prof Chi?
Do we have any other questions?
There is 3 more questions, but I will only take one from the audience, and we need to wrap up. Maybe in terms of central retinal artery occlusion, can we use ERG to know the onset and the prognosis of the disease? It's similar to what would you suggest, Prof Graham? Prof Graham?
No, not really. I mean, the main value of the ERG and CO is when the retina is reperfused, and then if the retina is reperfused, you get reduction in the oscillatory potentials, and that may be the only thing you'll see. The oscillatory potentials, which I didn't mention, the small wavelets on the ascending limb of the beach use. But other than that, there's not a lot of role. I don't know VIA if you want to find out whether it's ischemic or not. But neither are particularly mainstream.
Got it. Okay, perfect. Maybe let me ask a question that I had in mind before we maybe pass it again to Prof Chi. Obviously, it's tricky to do ERG properly but also it's difficult to interpret the signal properly. Do you think there is room for ERG in the community to screen or detect eye disease or diagnose conditions within the community? Is there a horizon for this? Is there for ERG in the community?
That's a challenge. It depends entirely on the context. I mean, if you, for example, there are now these handheld devices made by a number of manufacturers, and they do a very quick 30 hertz flicker ERG. Now, if, for example, you've got a pediatric practice in the middle of nowhere, and the kids have got JIA, juvenile arthritis, you want to know whether the eyes are involved, then doing a quick flicker ERG, you can tell pretty much quickly whether there's a delay or not, and they can then be transferred out. So if you've got an already established inflammatory disease, and you want to know whether there's efficacy, which can be done in the community, assuming that other people are going out into the community and not just, I mean, there probably would have to be an ophthalmologist. It wouldn't, possibly an optometrist, I suppose, that would do. Then again, you could just monitor the efficacy of treatment. If somebody's treatment is maintaining a flicker ERG delay, or the delay is getting less, then the treatment is having efficacy. But if the delay starts to increase again, then that's a bad sign. And so possibly, but you'd have to curate the nature of the disease, who's going to do the testing, and what the population is. The screening tests, they're pretty good, but we did some work on birdshot using both the handheld and the conventional Gansfield when I was at Moorfields. It was never published. They mostly agreed, but occasionally they were discrepant.
Okay, excellent. Prof Chi, any further questions from your side?
Do we have any more time?
I think we need to wrap up, but if you have any burning question, we can. Otherwise, we can just wrap up.
From the audience, take the audience. Oh, sorry, Caroline.
I think there was one quick question, and probably one question which probably just would have very simple answer. Would electrophysiology, say VEPs or ERGs, help you prognosticate post-op vision in very severe cataract cases? I mean, if you have a patient with a hand movement cataract, would it be of any use to do electrophysiology? My feeling is no, but I might.
Before or afterwards?
Before.
Before.
So if you have a very severe cataract in a patient.
The only well, if it's very severe, you're going to mess up what's going through.
Yeah.
The real thing comes in when you've got a patient who's got possibly mild macular disease, and a cataract which is under consideration for surgery but is not very severe. And then the question is, do your VEP, it's going to be delayed. So is the delay due to a cataract? Is the delay due to maculopathy? And for that, we can do what's called a focal ERG. So we use the same stimulus size as a conventional pattern reversal. But instead of having lots of squares, we just have 4 big squares. So it's a focal luminance response. And that will not be affected by the opacity, and will give you a luminance response coming from the macula.
Nice. Okay.
Okay, that's brilliant. Well, thank you very much for an illuminating talk. And thank you very much to the audience for staying on till almost dinner time. And apologies for getting in late. Thank you again.
Thanks again, Prof Graham, Prof Chi. Thanks again for hosting and giving the talk for tonight's webinar. So just a quick reminder, the next webinar is not in December, it's in November, 26th of November, same time. It will be given by Prof Gabriel Kreumann and hosted by Prof Diembo Liu from the Department of Ophthalmology. So yeah, we'll see you next time. Have a good evening. Have a good day, everyone. Thanks again, Prof Holder and Prof Chi.